What is the agent of transmission? The black fly. What's the biological name? Simolium. Simolium species. Black fly. Everybody's saying black fly. But you should also know that black fly is the same thing as Simolium. Now, what sample should be sent to the laboratory for confirmation of your skin snip? Okay. Why skin snip?
To detect for the microfilaria.
But why?
Because there's accumulation of the parasites.
Yeah, it's a tissue roundworm. Where are the adult worms located? Exactly. So the adult worms are located in the subcutaneous tissue. That's where the mate, the female worm, is viviparous. That means she's not laying eggs like the other parasites that we said. So she hatches the eggs within her body, then she releases the juvenile worms. So you're likely to get it. The adult form, I don't understand what that means, lean. They don't move, so they will be found there. What doesn't move? The adult worms don't move, but the microfilaria, they do, because the microfilaria are responsible for the pathological features and clinical symptoms. We can see microfilaria in the blood, yes, if you have heavy infection. Usually, the microfilaria of Onchocerca are located within the lymphatics and subcutaneous. But with heavy infection, you will have a spillover into the blood. What other sample can you send to the lab apart from the skin snip? Very good. In this case, what are you going to see? The adult worms. Very good. So that's the difference. The skin snip will show you the juvenile worms. The biopsy will show the adult worms. What precaution should be taken when you are collecting a skin snip sample?
It doesn't go so deep.
What?
You don't take a deep one.
Very good. You don't go too deep to cause bleeding. Okay? Very good. What is the difference between skin snip and biopsy? A biopsy takes the entire layer of the skin. So you're going to go through the epidermis and the dermis. Okay? With a skin snip, you're only going to go through the superficial layers of the epidermis. You don't get to the dermis. The moment you see blood, then that is no longer a skin snip. That means you've gone through the entire levels of the epidermis. Okay? Is that okay? Okay.
What would be the most appropriate drug to treat this condition? Which one? Ivermectin. Okay, ivermectin, very good. Everybody knows ivermectin. Let me tell you the history of ivermectin. For this drug ivermectin, I think in 2003 or 2, Nobel Prize was given to a Japanese who actually described the role of ivermectin, Nakamura sensei, something there. So because this drug ivermectin has contributed in preventing the morbidity and mortality in millions of patients in African region, Sub-Sahara, West Africa. And the good thing is that it is provided free by WHO, and the manufacturer, the arrangement is, it is provided free ivermectin to the African countries to prevent that river blindness and Onchocerca. So ivermectin is the
albendazole can be used.
No, albendazole for plasma.
no.
They wrote here albendazole.
No, that is albendazole was for cysticercosis caused by
Yeah.
trinosodium. Okay, that's okay. Albendazole for cysticercosis, but here we are talking about river blindness, which is mainly praziquantel. ivermectin. Case 3. Okay. Okay.
So a 40-year-old male expatriate while visiting his home country developed diarrhea. I think I'm going to remove this. I'm uncomfortable.
Okay.
Just a minute. A 40-year-old male expatriate while visiting his home country developed diarrhea with cramping abdominal pain. The pain was initially mild with Ward 3 diarrhea. He visited a nearby clinic for treatment. His physical examination revealed a temperature of 38 degrees, heart rate of 90 per minute, blood pressure of 110/70, respiratory rate of 16 per minute. His abdomen was soft with mild lower abdominal tenderness, and the rest of his examination was unremarkable. Stool examination showed clumped red blood cells, together with few pus cells and macrophages. One of the 3 fresh stools examined on consecutive days showed the following. What can you see here?
Can you figure out what is this?
People are already saying it.
Everybody knows.
Okay. So what's your diagnosis? Amoebiasis. Intestinal amoebiasis.
Okay, sorry, I want to just clarify the concept. So, intestinal amoebiasis can come in various forms. It can be asymptomatic pasa. Since this is an infection of the trophozoite, it will be to be specific, microbiologically and clinically specific. It has to be invasive intestinal amoebiasis. It is invasive. Intestinal amoebiasis can be asymptomatic stool cyst pasa also, but this is invasive.
No spelling, no spelling. Doctor, can you come closer to the mic? Okay, I'm closer to the mic.
Yeah.
What do you mean by no spelling? Lynn?
No spelling?
Is that a question? I'm confused. Why not Gadia? Ah, good. Let's go back to this. What can you see here?
I can see the nucleus with 5 chromatin at the end.
Okay, one at a time.
The trophozoite eating the RBC.
Ah, yeah. This represents trophozoites with ingested red blood cells, which is pathognomonic of Entamoeba histolytica. The non-pathogenic strains do not ingest red blood cells, right? Apart from that, we have here a trophozoite. Yeah, what can you say about the nucleus?
It has just a central chromatin with a fine around the edge.
Which is highly suggestive of.
Yeah.
So why do you think this is not Gadia?
No, these summer.
Apart from that, Gadia doesn't show red blood cells. Gadia doesn't invade. Remember, it's a surface pathogen. We said that. Okay. And the cyst and the trophozoites of Gadia, they are different, right? How do we classify Gadia? Flagellate, very good. And this is what? Sarcodina, right? It moves by producing pseudopods. Are you clear now? The cyst of Gadia looks different. Yes, that's the face of the old man. Okay. They have pear-shaped trophozoite. Very good. So are we all clear this is not Gadia? Okay, good. So what is the life cycle of this parasite? Direct. Why? And what is the infective form? Direct. Only one host. Good. So what's the infective form? Very good. How are humans infected? Fecal-oral. Very good.
How to manage this patient? metronidazole, okay, so they have mentioned the students at home, Imam and others, Nida have mentioned metronidazole, and Lean Al-Oteb has mentioned epramycin. I think you are mixing with paramomycin, not epramycin. Okay, paramomycin. So since obviously, as Mohammed mentioned, the infective form is a cyst. So while this is apparently invasive amoeba cell, but you can very well appreciate or understand that cyst must be there. Okay. So by killing only the trophozoitic form will not cure the person. Actually, you have to kill the cyst as well. So here, the management of choice would be to give tissue amebicide as well as to give luminal amebicide. So metronidazole plus one of the iodoconolone, diloxanide, furoate, or paramomycin. So this is the standard treatment, a combination of luminal and tissue amebicide. Okay. The patient was advised to take tablet metronidazole for 5 days. His symptoms were relieved after 3 days, and he was feeling quite well within a week after treatment. We didn't give him paramomycin or diloxanide furoate or iodoconolone, luminal amebicide. Now see the problem. What happened? Okay, we discussed it. What are the innate? Do you want to call this? Maybe in the GI block?
Yeah, no.
Okay, okay. 3 months later, this patient presented to a hospital in Riyadh with upper abdominal pain and fever. The pain had started 3 weeks ago. The fever started a week ago. On examination, temperature 38.5 degrees Celsius, pulse rate 110 per minute, blood pressure 110 over 70 millimeters of mercury, respiratory rate 20 per minute. He looked pale and dehydrated. His abdomen was soft with tenderness limited to the right hypochondrium. Okay, right hypochondrium, you know. Liver was palpable 2 centimeters below the right costal margin. The rest of the examination was unremarkable. What is happening now? So liver infection, liver abscess, everybody, this time it's liver abscess. Very good. Okay. Amoebic liver abscess. How would you confirm it? Hmm? Biopsy. Very non-invasive. Non-invasive. In 5 minutes you can confirm it. Ultrasound. Simple ultrasound will tell you this is liver abscess. His investigations are hemoglobin 11.5, WBC 16.7. They are mentioning CT scan. Okay, CT scan and scan can be used to confirm, but initially it is the ultrasound which will actually almost confirm the diagnosis. It is very non-invasive and easy. LFTs showed mildly increased bilirubin and moderately elevated alkaline phosphatase, aspirate, transaminase, and ALT. Stool examination of the 3 fresh stool taken on consecutive days showed no OR or cyst. This is, we purposely put here that in spite of the fact you are not seeing OR and cyst, but it is highly likely that cyst may be present. A CT abdomen, however, showed the presence of a liver abscess. Which type of liver, we can confirm, which type of liver abscess is most likely in this case? What is the other type of liver abscess? Apart from amoebic liver abscess, pyogenic liver abscess, pyogenic due to bacterial infection. He was advised serum test for the detection of Ent-amoeba histolytica and heterogeneous antigens in the serum. EIA for Ent-amoeba histolytica antibody spelling is incorrect, was positive, while that for hydrated antigen was found to be negative. Why would you suspect a hydrated cyst here? What is hydrated cyst? Echinococcus granulosus, which is a cystode. Okay, so by chance, by accident, the human may get infected. So it is a dead end for the human Echinococcus granulosus. So because the clinical picture resembles very much similar radiated cyst and amoebic liver abscess. So this serology test was done. Darwin, Darwin, would you want to cover this?
So
This is a case of amoebic liver abscess.
all right. So
So-
what is EIA? Is it EIA?
Yes, yeah.
Enzyme
No. You're missing some letters.
Yeah,
ELISA.
Eliza.
No, it is not ELISA. It is not.
enzyme amino acid.
Oh,
It's
enzyme-
immunoassay.
enzyme-
Immune acid.
Yeah,
No, it should be ELISA. Enzyme-linked immunoassay.
immunosorbent acid.
Or,
ELISA immunosorbent.
huh?
ELISA immunosorbent acid.
This is this is different from ELISA.
Yeah, anyway, we
Okay.
have EIA in the original.
This I think this is not the objective of this graph.
Yeah.
Is there a relationship between the current illness and his past diarrhea in his home country? Obviously, because we didn't treat to cure the patient at home country, we should have given a luminal amebicide, which we didn't give. So this happened. How did the parasite reach the liver? Through portal circulation. Okay.
How was the organism able to get?
Hepatic portal, okay. It came in the cells, okay.
Let me just ask a follow-up question.
Okay.
Yes. So how was the organism able to access the portal circulation? Pardon? The organism is invasive, unlike Giardia, remember? So it can actually burrow its way using hydrolytic enzymes to get to the submucosa and access the blood circulation there. Good. Yeah, it's invasive.
They said invasive, huh?
By getting into the submucosal vessels, yes.
Submucosa.
Oh, okay. This is me. What is the treatment now? Is it different from the previous one or the same? Hmm?
Same.
Same, but there is one small difference. Hmm? Same, but one small difference. You can add another drug. Oh, yes.
Yeah, I,
Chloroquine. Chloroquine has found its role in treating hepatic amoebasis. Chloroquine in low doses has been found very, very effective. Actually, in the official guidelines, chloroquine has to be given, as Santosh might have taught you in his lecture, that when there is some contraindication to metronidazole, then it can be replaced with chloroquine. But let me tell you, the standard practice everywhere, almost everywhere, even in Saudi Arabia, the standard practice is it has to be given in combination. Metronidazole plus low dose chloroquine together, plus one luminal amebicide. 3 drops. Okay, this is
Okay. So we have a young child who was brought to the clinic by his mom. She was worried because of the skin condition as shown in the picture. She said her child's friends are avoiding him and he's very sad about this. What can you see? What can you see? Well, how would you describe these lesions? Hypopigmented patches or rashes on the side of the face. Good. How would you classify? Okay, everybody's been writing that. Superficial fungal infection. That's very good. Hypopigmented.
tinea corporis?
Stenia.
No, this is
Tinea
tinea vesicular.
Basically.
Yeah, tinea vesicular. So how would you classify this? It's a superficial mycosis, yeah. What characteristic of this fungal agent allows for infection of the skin? Did you look at that table in the lecture? No, you all didn't look at it.
No one
The
else.
skin has a lot of keratin, right? So these are keratin-loving agents, so they are keratinophilic. So because they can digest keratin, they tend to go for the skin and the appendages, the nails, the hair, okay? So
Is this table with us? Like the,
I think I gave you the table in the lecture with the mycosis, disease they cause, why, and representative organisms. Check again.
yeah, I remember you mentioned it's not with us. Like we don't have to.
Ah, okay. So you didn't look at the table. Aerobic, yes, they are all fungal agents are aerobic. Good question. What does that mean? Don't dermatophytes infect ear nails? Yes, they do. Dermatophyte is another group of superficial mycotic agents. Remember I told you in the lecture that when we say cutaneous mycosis, you can divide them into superficial and cutaneous. Superficial is tinea vesicolor. The dermatophytes are more of cutaneous. That's the trichophyton and the microsporum and what have you. Is that clear? So this agent actually is not a dermatophyte. With dermatophytes, you know, we didn't really discuss the disease process. But now that this is coming up, let me just say that with dermatophytes, they tend to cause circular lesions that spreads out. Yes, the ringworm, very good. As you can see, these are just patches. They don't have that coin-like appearance. So this cannot be a dermatophyte infection. Is that clear? So that's why we say superficial and cutaneous.
So one question here, do we have to study the tables?
It's only one girl.
You can spy with your little eyes. It's there, it's part of the lecture, right? Basically, we have to study everything.
Yeah.
Ah, good observation. I thought we only had to know the types of skin infection. Well, that's part of knowing the type of skin infection. If you know the skin infections, you don't know what layer.
What do you mean by skin infections? Like the names of the.
Name of the fungi?
Yeah.
I just explained to you now that we can say cutaneous mycosis, right? But you can have superficial and you can have cutaneous. So you should be able to.
Do we have to know what each one, how the mechanism of it?
It's up to you. Based on the discussion, what do you think? It's up to you now. What do you think?
You decide not to
You
read.
decide. So this is going to be in the exam too. I don't know. Should ask Dr. Atif. Doctor, which fungus is responsible again? Malassezia furfur. Malassezia, I think you're right. Tinea vesicolor caused by Malassezia. Very good. This is superficial mycosis. You're right. Okay, so what else?